Welcome back to Mostly True Psychiatry with Dr. Mellon. So today we're going to be going over the treatment of MDD, and I'll put a link to this graphic below for a Google Doc so you can download it. So basically what I'm going to be going over here are the three drugs, or three groups of drugs that the last videos were going over. So it's the SSRIs, the SNRIs, and then 5 drugs you're likely to try. So I tried to make this table just to be super functional for like real residents and people just trying to learn how to practice and do their job. So I put in basically a starting dose for 2 different patient populations. You have frail or somatic or normal adult. Normal adult is just like a perfectly healthy person kind of thing where you're not scared of hurting them. A frail person being anybody that's frail. I mean, this could be a geriatric patient. This could be somebody who's had a liver transplant. This could be somebody who is currently in the hospital and has had car wrecks and stuff recently. Just they're frail for whatever reason. For somatic, it means that they're going to complain. They're going to say they have side effects. You know they're going to say they have side effects. So you just tell them that you're starting them on what's probably a placebo dose. You just want to make sure that they don't have any side effects. Good to go. Patients aren't going to think that's weird. It's fine. You just tell them that. This is basically your monthly increase for these drugs. Like Floccitine, you're going to go 20 milligrams a month is what I'm going to argue, and then a max dose to where you don't go over that. You're just getting side effects, and if you want to cause side effects to get a placebo dose or placebo effect, do something that's helpful for a placebo effect. Have them go exercise or something. I'm going to list who's a good patient. These are patients you should give it to, and you'll look smart. Bad patients, the ones you should avoid so you don't look dumb. And then why the drug sucks, right? Every drug's got a problem. So we'll start with Floccitine. Everybody starts at 10 milligrams a day. It's a very slow drug, right? It takes up to 35 days for some people before it's at steady state. So everybody starts at 10 milligrams a day, but normal people after that first week, you go ahead and bump them up to 20. You should just go up at 20 milligram increments, because if you went up 10 milligram, from 20 to 30, because you're doing that 10 milligram garbage, they might not even be at steady state at the point you follow up with them. So you still don't even know how the drug's affecting them. So don't be weird. Just the drug is sold at 20, 40, 60 milligram kind of increments. Don't make a person take 2 pills. 80 milligrams is as high as you should go. Floccitine and Sertraline are the 2 drugs that are supposed to be good for Eeyore, so that Winnie the Pooh character where he's low energy, he's tired, he's anhedonic, that person. So it's supposed to be stimulating. That's basically the argument. So Floccitine's good for those. It's good for kids 8 and older and also for people for poor compliance. It's good for kids 8 and older because that's the FDA approval. There's only 2 drugs you give to kids. This should be your first line one because it has such a long half-life. They don't get withdrawals, and basically any of the other drugs with any missing doses and stuff can make the kid feel bad. He'll get withdrawal effects. So it's basically your go-to first line. Because it's activating, right? This should be bad for people who are super anxious and have panic attacks. If they're frail or old, I would say it's actually a bad drug too, because it's a messy SSRI. As you increase the dose, it starts hitting. It's a big fluffy old molecule. It's not like a pure SSRI. So it's anticholinergic, which is bad for old people. Norepinephrine, dopamine starts getting hit. So those all cause more side effects. Sertraline, everybody starts at 25 milligrams a day. It's basically how long are you going to wait before you get off that dose, because it causes GI upset, particularly just when you start it. But so you start at 25 milligrams for everybody. If they're healthy, 2 or 3 days later, it's fine. They just go up to 50 milligrams. If they're really, they're going to complain or it's really frail, you wait as long as you want. 7 days should be fine. It's hard to believe that it's anything other than somatic outside of that, but you could go 10 or 14 days if you really wanted to. You should go up in 50 milligram increments. So it goes 50, 100, 150, 200. So it's a lot of steps too. This is a good drug if you want to micromanage it and try to do that as part of the placebo effect and like you're doing something with the patient. Floccitine and Sertraline are supposed to be stimulating, so they're both good for Eeyore. There's evidence that probably because of just randomness, but it's particularly good for Parkinson's disease. And actually, Sertraline is basically your go-to first line for pregnant or breastfeeding. So there's very little of it in the breast milk. It's been shown to be, it's basically has a good body of evidence. It's safe. Because it's good for Eeyore, it's not good if they're panicky, and it's really bad because of the GI side effect. For paroxetine, This is a weird drug. You're not going to prescribe it a lot. It's also weird because it comes in IR and CR. It has 2 different doses. They're 20% roughly difference at low doses, but somehow they're 1 or 2% difference when you get to the max dose. I don't get it. But realistically, it's kind of sedating, so it's supposed to be really good for anxious patients. So it helps in the short run when you're first starting it. So if a person's really anxious, it helps really in the first days to week or so, and then it should have the same kind of end point as all of the other SSRIs when it comes to a person who's depressed with anxiety. I guess that would mean the IR is probably good for trying to oversedate a person to help with that anxiety. Otherwise, you pick the controlled release because you want less side effects. And then you add plus 10 or 12.5 milligrams per dose, and then they both cap out around 60 milligrams. This has the shortest half-life of the SSRIs at 21 hours, so it's supposed to be the worst with withdrawals. So it's actually the one you don't give to kids ever for any reason. But yeah, so it basically is only given because of the real anxious patient kind of thing. It's supposed to be the worst when it comes to sexual dysfunction. So if they're having a problem with sexual dysfunction with one of the other SSRIs, this one will just be more of the same. Citalopram and escitalopram are the cleanest versions of the SSRIs. They're both pretty good for just like geriatric, frail, somatic patients. One of them's just the isomer, one isomer taken out from the racemic mixture, so it's just half the dose. So if citalopram's 10, escitalopram's 5. So starting dose is, they actually have capsules this small and everything, so it's fine. So it's the 10 milligrams for citalopram, 5 for escitalopram. Otherwise, it's always 20 and 10, and they only have one increment step up, so 20 to 40 or 10 to 20, which makes it quick and easy also for trying to get a person help with their depression if you think increasing the medication dose is going to help. Even though they're both good for geriatric, frail, somatic, the one difference is that citalopram you don't give it to people with any kind of cardiac problems because they know it causes a prolonged QTC interval. All right, let's move this. All right, so for the SNRIs, you've got 3 drugs. Venlafaxine, I put XR on here. You're never going to give it IR. The first drug was not called IR, just they had to extend it because the side effects sucked. So you can give 37.5 milligram tablet for people that are somatic, or everybody else gets 75 milligrams. You do it in the morning. All the SNRIs you don't want to do late at night because they might keep them awake from the norepinephrine is the argument. So you can go up 37.5 milligram tablets with it, and 225 is your normal cap out. An interesting thing with basically venlafaxine and Daloxetine is they're good for people with migraines. So if they have a migraine history, this is the drug to go to, even though they cause headaches. It's pretty weird. So basically all the SNRIs should be like Floccitine and Sertraline. All 3 of these 3 drugs and then Floccitine and Sertraline should all be good for EOR, people with low energy, fatigue, that kind of thing. Specific to the SNRIs is we often give them for pain, neuropathy, this kind of stuff. So just general neuropathy is going to be venlafaxine. The thing about venlafaxine, why I particularly don't like this drug, to be honest, is other than benzodiazepines, basically other than benzos, you're not going to run into anything that has as bad a withdrawals as the SNRIs have. If a person's on 225 milligrams for 5 years, it might take you months and months to get them off that drug because they're going to feel like garbage within a couple days. Dizziness, flu, all sorts of craziness. Duloxetine comes in your 20 milligrams for the frail folks, 30 if they're normal. So the thing about this drug, so you're shooting for 60, right? If the person doesn't have side effects from it, if they're doing okay, you actually just go 30 milligrams in the morning and then 60 milligrams in the morning. So it just has 2 doses, which is actually pretty cool. If they get kind of headachy and stuff from it, then you have to split it and you have to do 2 30 milligram capsules. And basically, you can't do it late in the day. I usually just tell 3 o'clock is the end point. You don't want anybody to do it after 3. Think of it as them taking coffee. Just tell them to not take it any later than they would drink coffee or something. Duloxetine got lots of neuropathy, fibromyalgia, chronic pain, is those written down as all of its extra stuff. So you can sound smart like a pain doctor and you give them Duloxetine for depression, and it's basically just a patient with back pain, right? They got a lower back injury or something. Duloxetine, basically the thing you always have to be aware of, it can cause hepatic failure. That's the reported risk. I don't know if it's actually true or not in the real world, but that's the written down research angle. So if they have any kind of liver dysfunction, do not give duloxetine. Desmond Lafaxine, kind of the newest one that came out. It's you have venlafaxine. They took out one of the enantiomers. You start at 50 milligrams for anyone, and you end at 50 milligrams. So it's a one-dose drug. You give it to somebody because they got more money than sense, and they only want the best. Hot flashes are supposed to be one of those things. So postmenopausal women with depression, it can help, or just to help with hot flashes. Anybody that's very anxious, you can give them. If they got a lot of money, that's fine. But otherwise, that's usually considered a reason the drug sucks. It's expensive. Now, for the last ones, 5 drugs you're likely to try for major depressive disorder. So you got Lamotrigine. Everybody starts at the same dose. It basically has a fixed titration schedule because Steven Johnson syndrome sucks. That's why the drug sucks. It's also a teratogene, so don't give it to women of childbearing age. It's 1 to 6%. It's considered low as far as the anti-epilepsy drugs go, like Keppra, levetiracetam or whatever. But still, if it was actually 6%, would you take a drug like that if you're pregnant? But everybody, so you get 25 milligrams a day. You wait every 2 weeks, you increase, and it doubles. So it's 25, wait 2 weeks, 50 milligrams, wait 2 weeks, 100 milligrams, wait 2 weeks, 200 milligrams, and then stay there. You're supposed to give it basically bipolar 2. You can give it as monotherapy. Otherwise, you can do it as an adjunct. Mirtazapine, basically, you're giving this to a person specifically probably for insomnia. That's really the patient. Like, it's depression with insomnia because the first 15 milligrams is just a sedative. You can give 7.5 milligrams if they're frail or somatic. Otherwise, everybody gets 15 milligrams. It goes 15, 30, 45 because you're doing 15 milligram increments. So the 30 milligram and 45 milligram are actually for depression. It's as good as basically all the other SSRIs, SNRIs kind of thing. It's also an antiemetic. So if a person has a lot of nausea problems, this is a good choice. Or if they're like, a cancer person and they're going to go through their chemo. Sexual dysfunction, if that's a problem because of the SSRIs and stuff, you can actually just switch to mirtazapine. That'll probably go away. It's not good if they sleep a lot because you're just causing more of the same. And it ends up with like these anticholinergic side effects. So dry mouth, constipation. I see dry mouth actually more often than you would think. Bupropion comes in 3 formulations, IR, SR, XL. Just give XL. Just ignore the other 2. Pretend they don't exist. So it comes in 150 milligram tablets. So you just start everybody on that. You go up by 150 and it stops at 450. So it has 3 doses, right? 150, 345. So a starter dose and 2 increases. This should be looked at as a first-line antidepressant as long as they don't have a problem with epilepsy or a seizure risk, like they're anorexic, they're an alcoholic, they have epilepsy, right? Any of those things, they have head trauma. But as long as they don't have that as a problem or liver problems, this is actually has been rated as good as like the TCAs and stuff. So like I said in the earlier video, so it should be better than most of the SSRIs. So this really should be a first-line medication, even though it still is put as like a second-line option behind SSRIs, SNRIs. Aripiprazole, and it's stimulating. Sorry, that's the ER thing there. So aripiprazole, it has a really, really low dose and to 5, so it's 2 milligrams or 5, and you're shooting for 15, really. You go up 5 milligram increments. You go 2 milligrams to 5, and then 5, 10, 15. It should just be an adjunct. You shouldn't use it as the only drug, and then it's an antipsychotic, so it's sedating. It makes people less aggressive. So if they're irritable, it's a guy, jail, really angry, depression, just got out after 40 years. It's a perfectly good drug to add on. I don't care what the drug reps say, always worry about overweight. They're going to get weight gain. Akathisia is a problem with this. If someone starts at 10 milligrams, they have like a 30% chance of having akathisia. If you go up slow, they're better. But they might get akathisia anyways as you go high, so you just have to check. The last one's Velazodone. So everybody starts at 10. You have to wait a week before you go to 20 because this causes nausea, diarrhea, and headache in everybody. 1 in 5 people dropped out of the studies due to that. And then once a month, you up 10 milligrams. You're going to 40 milligrams. You have to take it with food, too, because the bioavailability is horrible otherwise. So that's another reason the drug sucks. So it's new. It's cool. If they're rich, they want the best, go for it. All right. This has been Mostly True Psychiatry with Dr. Mallon.